you all here for here I had celebrating a newly established Nicholson Neurodiversity lecture series. And we're really excited because we have our inaugural lecture here today. This endowed lecture is made possible by Dinah and Steve Nicholson, whose visionary gift gives funds an annual lecture series that is going to bring and brings distinguished and disciplinary experts to OSU to give research presentations on neurodiversity, brain development, cognitive development, and fetal spectrum disorder. Excuse me. The series also hosts a practitioner workshop that's tied to the lecture, and that will be happening after this. And I will give a little bit more explanation. But first of all, let me introduce our great speaker here today. Excited. Dr. Sharon Stoner is here from the University of Washington. She's a research associate professor and the Anne Streiskuth Endowed Professor of Fetal Alcohol and Spectrum Disorders at the Addiction, Drug, and Alcohol Institute. This is from a med school, you can tell. Title on the planet. Okay, the Addictions, Drug, and Alcohol Institute within the Department of Psychiatry and Behavioral Science, Washington School of Medicine. Academic titles. As a licensed psychologist, she also directs the Washington Parent-Child Assistance Program, which provides 3 years of case management and recovery support services for mothers who have engaged in at-risk substance use during pregnancy. In this presentation today, we're very excited because Dr. Stoner will describe and discuss studies pertaining to the impact of prenatal alcohol exposure at midlife. So we have a talk from 12 to 1. We have a short reception from 1 to 1:30 after that. And then we're very excited because we were able to tie a practitioner workshop to this lecture series. And so today we're excited to have from 1:30 to 3:30 a 2-hour workshop for researchers and practitioners that will be led by the Facets Center for Neurodiversity and will focus on the Facets neurobehavioral approach. So I'm very excited all those. So without further ado, please join me in welcoming Dr. Stoner.
Thank you all for coming. I really am excited to see such a strong turnout here today. It really is an honor for me to be here giving the inaugural lecture. So thank you all for being a part of this. The title of my talk is The Enduring Impact of Prenatal Alcohol Exposure, Research Examining Fetal Alcohol Spectrum Disorders at Midlife. And there we go. So learning objectives today, I'm hoping that by the end of this talk, attendees will be able to describe the impacts of prenatal alcohol exposure at human development, be able to identify physical characteristics and health conditions associated with fetal alcohol spectrum disorders in midlife, and also recognize areas where middle-aged adults with FASD show similarities and or strengths compared to their peers without FASD. I have no conflicts of interest to disclose. So I wanted to pitch this as a pretty broad audience. I didn't want to assume that anybody knew anything about FASD or even research for that matter. So, apologize in advance if some of this is review for some of you folks, but wanted to be sure that we sort of covered the basics. So fetal alcohol spectrum disorder refers to a spectrum of effects that stem from prenatal alcohol exposure. It's an umbrella term that encompasses a range of different diagnoses from different diagnostic systems related to prenatal alcohol exposure. The most significant, but the first disorder that was discovered was fetal alcohol syndrome. And this refers to a permanent syndrome caused by maternal alcohol drinking during pregnancy, which is characterized by significant growth deficiency, severe brain impacts affecting multiple areas of the brain, including learning and memory, self-regulation, executive function, attention and communication, motor skills, intellectual functioning, and so on. And also the specific pattern of dysmorphological features, particularly in the face, that are viewed as sort of the cardinal features of fetal alcohol syndrome. So it's first sort of officially recognized in the early 70s by some folks at the University of Washington, including Anne Strauss-Guth, who's endowed professorship by Hold. But they recognized among 8 women who met criteria at the time for alcoholism, a pattern in their children, um, including some characteristic facial features. And these are the 3 hallmarks. So there's short palpebral fissures in the eyes, a thin upper lip, and a smooth philtrum, or the little indentation above your lip. Now, a lot of people wouldn't even notice this because they're not trained, but to the trained eye, they can really see this. And this is reflective of some higher impacts of prenatal alcohol exposure on the developing person. Could be impossible to detect in adulthood due to effects of aging on the face, and I'll talk more about that later. But I think it's really important to recognize there can be significant impairment even without the facial features associated with FAS. And that's why we use sort of the motif or the image of the iceberg that you saw on my slide, is like what we see with FAS is really just the tip of the iceberg, and a lot of the impact of prenatal alcohol exposure is hidden. Um, so yes, FASD is largely a hidden disability. So when we talk about fetal alcohol spectrum disorders, we're talking about a number of different diagnoses. There's fetal alcohol syndrome, of course. There's also something called partial fetal alcohol syndrome, where the person would have maybe 1 or 2 of the facial features, but also significant brain impacts and perhaps some growth deficiencies, but they don't meet full criteria for FAS. Under the diagnostic system called the 4-digit code that was developed at UW, we talked about static encephalopathy, alcohol exposed, and neurodevelopmental disorder, alcohol exposed. These are kind of degrees of impacts of prenatal alcohol exposure. I'm not going to get into the nuances of that. But under a different diagnostic system, sort of put forward by the Institute of Medicine, both of those things would be considered alcohol-related neurodevelopmental disorder, or ARND. Um, uh, then we also had alcohol-related birth defects, where you see impacts of prenatal alcohol exposure on other systems of the body, not necessarily the brain and the face, but potentially impacts to the musculoskeletal system or kidneys, other systems. And a term you're going to hear me say later is fetal alcohol effects. It's kind of an outdated term that was applied sort of back in the earlier days of FASD to sort of refer to kind of all of the above except for FAS. People who had significant impacts of prenatal alcohol exposure but didn't meet criteria for full FAS would be described as having FAE. And now sort of the most recent development that sort of came out with the DSM-5, or the Diagnostical and Statistical Manual of Mental Disorders, that is sort of the Bible of psychiatry and diagnostic systems used in psychology. There is a new condition recommended for further study called neurobehavioral disorder associated with prenatal alcohol syndrome. And that basically encompasses all of the above. People who have significant impacts of prenatal alcohol exposure in a number of different ways, who would meet criteria for any of these things. And it kind of opens the door for more people to be able to recognize and diagnose FASD, because otherwise you really need a physician to do a physical examination and look for the physical characteristics. But that's not strictly necessary with NDPAE. And so hopefully we'll be seeing more access to diagnosis among people who need it and can't get to your physician. So how common is FASD? It sort of depends on the population that you're looking at. Research done almost 10 years ago was looking at population of first graders, estimating that 1.1 to 5% of children were affected by prenatal alcohol exposure. And that might not sound like a lot, but that is actually more common than muscular dystrophy, cystic fibrosis, Down syndrome, and spina bifida combined. Um, Now, if you look at adoptees or children in the foster care system, what you see is are even higher rates. 6% were recognized as having fetal alcohol syndrome. 17% sort of were more broadly under the umbrella FASD. And if you look at juvenile justice context, it's estimated that almost a quarter have some FASD. Um, and in the adult criminal justice, it's estimated that one study found that over 10% met criteria for FASD, but there was another 15% that met criteria, but they couldn't establish that there was maternal alcohol use during pregnancy. So it could be quite a bit higher than 10%. Now, why does alcohol affect people when they're prenatally exposed? Well, that's because alcohol crosses the placenta freely. So 1 to 2 hours after a pregnant woman drinks, you see blood alcohol levels in the fetus that are very close to, if not the same as, blood alcohol levels in the mother. Um, Fetuses will actually swallow amniotic fluid that is basically a mixed drink, if you will. Um, and that increases their exposure time because it gets into their gastrointestinal tract. But they have underdeveloped capacity to be able to process the alcohol. Um, so when a pregnant woman drinks, so does her fetus. So as I mentioned, fetuses can't process alcohol. The liver does begin to develop in the first trimester, but it doesn't reach its full capacity for filtration until later after birth. So because a fetus has undeveloped metabolic capacity, it can't effectively eliminate the alcohol. And so it's sort of developing brain is being bathed in this for a longer length of time. And so the fetus really has to rely on the mother's metabolic capacity to process the alcohol to a great extent. And that really varies quite a bit from woman to woman. And so that's why, we can't really say that whether there's a safe amount of alcohol consumption during pregnancy, because I'll get into this later, there's just a lot of different factors that impact it. So alcohol is recognized as a teratogen. Teratogen refers to substances that have the potential to damage the fetus when exposure occurs during pregnancy. And we understand the degree of damage is really depending on the timing and the dose of the exposure. If the timing and dose are below a certain threshold, there may be no impact. You might not see malformation, but above a threshold, you start to see increasing effects. You can really see this in a mouse model. On the left, you have a typically developing mouse fetus, and on the right, you have a prenatal alcohol exposed mouse. And you can really see sort of the difference here in the lip and philtrum and in the eyes, which we see in humans. So we recognize that maternal heavy drinking in the first trimester has the worst impact, but damage can occur really in any trimester. And a lot of people don't find out they're pregnant until they're quite a ways into the pregnancy. And at that point, if they're heavy drinking, they have an intended pregnancy, it can be kind of too late to change course. Obviously, the sooner you stop, the better, but there may have been damage done. And as I mentioned, there's just too many variables to be able to estimate a safe amount for one mother with very good metabolic capacity. There might be lesser impacts than with another mother, so it depends on the timing, the dose, talking about when in the pregnancy, how much are they drinking, how often are they drinking, but also the mother's genetics, also the fetus's genetics impact it, and also nutrition, general health, maternal stress, infections, things like that. So to be safest, we say there should be no alcohol use during pregnancy. And yeah, if you're pregnant, don't drink. So brain damage for prenatal alcohol exposure can be diffuse. The teratogenic effects are really widespread in different areas of the brain. But there is high variability from person to person, and we don't completely understand why, which also can be related to timing and dose of exposure, all of those other things. But MRI studies done in children have found reduced brain volume, alterations in shape and thickness of the corpus callosum, which that arrow is pointing to if you're not familiar with brain structures, but also the basal ganglia, the hippocampus, amygdala, and the frontal lobes. So, as you can imagine, impacting a lot of different types of functional behaviors. We know that prenatal alcohol exposure alters the development of the hypothalamic pituitary adrenal axis. And this relates to how people respond to stress. Weinberg et al. Found that people with prenatal alcohol exposure, or actually even animals with prenatal alcohol exposure, over respond to minor stresses in terms of their cortisol release. And that affects the body's response to stress and anxiety. And prolonged exposure to stress can be toxic unless you have some mitigating factors like supports, protective relationships, skills in a human. So, in fact, it's important to point out, sort of at low levels of stress, generally speaking, some stress can actually be helpful. We talk to graduate students, sort of trying to be, productive and study for their qualifying exams. A little bit of stress is going to sort of help you get prepared for that. But above a certain threshold, it's tolerable, but it's not helping. And then if it gets even higher, it starts to break down and you get sort of potentially impacts of stress. You can get sick, for example. So if you can imagine in a person with prenatal alcohol exposure, if they're sort of over responding to stress, they're going to get into that toxic zone a lot faster than somebody without prenatal alcohol exposure. The fetal programming hypothesis, it talks about how antenatal events can sort of program the body and the brain to have a lifelong impact. And so there are a lot of factors that sort of go in. We have sort of this funnel going down related to maternal nutrition and health, also maternal substance use, maternal stress and infection, all sort of programming the developing fetus and their stress system. And those impacts sort of alter their trajectory in their postnatal development, putting them at increased risk for metabolic disorders, cardiovascular disease, immune dysfunction, and mental health disorders. Also want to note there's the primary disabilities that come from prenatal alcohol exposure, but then there's also secondary disabilities that come from that exposure as well. The primary disabilities are direct effects of prenatal alcohol exposure, and those might be difficult or impossible to improve over time. For example, IQ impacts or memory problems, emotion regulation problems, although people can learn to compensate for them. They're still there. But then beyond that, there's sort of the secondary disabilities that sort of result from those primary disabilities, like problems or conditions arising from them, such as trouble with the law, some mental health problems, substance use disorder. They can come from some impaired self-regulation, for example. These can be improved over time with adequate supports and interventions. So this is some actual quite old data from Anne Streiskuth looking at secondary disabilities across the lifespan. So she looked at people diagnosed with FASD at the University of Washington later on between the ages of 12 and 51, and looking at sort of a variety of different potential problems that she sort of conceptualized as secondary disabilities. And what's really interesting here is that you see, generally speaking, you have higher rates of so-called secondary disabilities among people with FAE, not FAS. Why might that be? When you think that folks with FAS, wouldn't they have more severe disability because they have sort of the most severe diagnosis? Well, that's not necessarily true because they came into UW, they got a diagnosis early on, and because they got a diagnosis early on, they got supports. But people with FAE are not recognized in systems, in schools, for example, and they're not getting supports that they need. And so you see the higher secondary disabilities in folks with FAEs. So looking at this, I found the risk factors for secondary disabilities included having an IQ over 70, and as I mentioned, diagnosis of FAE, But also other risk factors are substance use in the home, not having their basic needs met, exposure to violence, and also being male. The boys had worse problems. But on the flip side, protective factors including having a stable and nurturant home, getting an early diagnosis before the age of 6 so that you can actually get the supports that you need, and having those supportive services, and also being protected from violence. So just to summarize what we know about prenatal exposure and its impacts, there's no safe level of drinking during pregnancy. The more alcohol consumed and the more often a pregnant woman drinks, higher the FASD risk. The first weeks of pregnancy appear to be most sensitive, but there can be impacts throughout the pregnancy. PAE causes both primary and secondary disabilities. Those with more severe FASD or FAS need and often receive more support, but that reduces their secondary disabilities. On the other hand, those with less severe FASD, like FAE, are more hidden and unlikely to receive supports that they need. So I do want to know, having only been officially recognized starting in 1973, FASDs are really young disorders. We haven't known about them for a long time. I mean, I've been alive longer than that and aging myself. But there was a time in my lifetime, my peers, our mothers, did not know not to drink alcohol. In fact, some physicians were actually recommending it. Have a couple of drinks. It'll help relax you. It'll calm you down. We actually might be seeing some similar things with cannabis now, right? But I also want to make sure I point out that FASDs are not strictly disorders of the young, right? It's understood that they don't go away. People, their children with FASD grow up to become adults with FASD, really don't know enough, officially speaking, scientifically speaking, about FASD across the lifespan. And so that's where our research sort of comes in. We know that adults with FASD report an array of health concerns. There's kind of a landmark study called the Lay of the Land Survey conducted by a group of folks, adults with FASD, called the Adult Leadership Collaborative and the Change Makers. They put out a survey and got 541 responses of people with FASD, and they were reporting health concerns or health conditions that they had across a whole number of domains, which I'm not going to repeat here, but whole body, right? So we started to look at FASD, particularly when aging, as a whole body diagnosis. Might not be evident in childhood, but it becomes evident over time. And that this leads to concerns about so-called premature aging. For example, it seems that arthritis might be happening in folks with FASD earlier than you might expect in typically, not prenatally alcohol exposed people. So why is it important to know about this? Well, we want to develop a wider understanding of the risks associated with prenatal alcohol exposure. We want to get the word out there to clinicians to improve clinical care for affected individuals. We really want clinicians to kind of be vigilant for these things that they might otherwise not recognize because, you're not old enough for that yet. If they know that their patients have prenatal alcohol exposure, they can be sort of primed to be looking for potential impacts along with aging. We also want to identify areas where early intervention may be most effective to limit incidence of these health conditions or severity. For example, with cardiovascular disease, it might be really useful to have physical activity interventions earlier in life, for example. It might have particular impact in that population. And just in general, we want to improve quality of life in folks with FAS. So how can we learn about this in a research context? Well, there's survey research like the Lay of the Land survey that I mentioned. That's very useful. Also qualitative work, so getting out there, talking to people with FASD and their families. What are they seeing? Also, biomedical research has an important role. Looking at biomarkers. We're involved in work looking at biomarkers of inflammation and immune function in adults with FASD. But it's important to do controlled studies. Why? Well, we want to control for factors that might also play a role in health development of health conditions. There are a lot of variables at play in real lives, right? I've also already mentioned timing and dosage or communal exposure. You want to try to understand what it is about that. But then there's the indirectly related things. You have childhood adversity that is experienced by a lot of people, not everybody with FASD, but a lot of people with FASD. And how does that sort of play a role? Maybe what we're looking at, we think is a result of prenatal alcohol exposure, but it's actually a result of childhood adversity. So you need to sort of tease these things apart. Um, there's also impacts of stress in adulthood, socioeconomic status, all kinds of variables potentially impact development of health conditions. But then there's also unrelated variables that are gender, race, and ethnicity. And sort of how does that play in? So controlled studies can really help us to tease these things apart so we understand what the mechanisms are. So as I mentioned, my group, the Fetal Alcohol and Drug Unit at ADAI at University of Washington, is involved in a multi-site research with some partners, and we all have a population of people of adults in midlife with FASD. Whoops, I don't know how that got there. The Seattle cohort is a group of folks who were diagnosed with FAS or FAE back in the 70s to 90s by Ann Booth and colleagues and participated in studies at that time. That group is mostly white. The second highest race is American Indian. There's a different cohort in Atlanta of people who are not necessarily diagnosed with FASD, but their mothers came in when they were pregnant and they assessed how much alcohol they were using. And those folks were all examined for dysmorphological features, but they weren't formally diagnosed after birth. But they were diagnosed in the 80s. And so now they're also approaching midlife, or they're in midlife. And being in Atlanta, that population is mostly African American. And then there's a cohort in Vancouver, and Canada has really great systems sort of supporting people with FASD. And so they're able to effectively recruit people from the community and enroll them in studies. And their population is mostly white, and the second highest is Indigenous. So if you just look at some demographics here, sort of broadly representative, different studies, different things that we're looking at, depending on, where there's missing data. It looks a little bit different, but in Seattle, we have our participants range in age from about 30 to almost 70. Atlanta is a bit younger, and Vancouver has a bit of a wider range. You can see Seattle is mostly male, where more than 50% male, whereas mostly female in Atlanta and Vancouver. And I already mentioned sort of how the race and ethnicity shapes out. Here's just a different way of looking at overall. We do have more female participants in our research, and it is almost 50% white, but we also have quite a representation of Native American across the groups. Native American or Indigenous folks and African American folks. So our general study methods in Seattle and Atlanta, past research subjects were invited to participate. They completed questionnaires related to their health, and then a subset of people came in and they had a dysmorphology examination. They completed a variety of different blood draws, and at University of Washington, a group of folks also had brain imaging. So there was a health survey, which was self-report survey. So it's kind of limited to people's own knowledge of their own health. They weren't sort of getting examined for the health by a physician, but they were able to report on their own understanding of their own health status and diagnoses. There were skip patterns. There were up to 190 items in this questionnaire. It was adapted from the Behavioral Risk Factor Surveillance System, or BRFIS, that is generally conducted by the Centers for Disease Control and Prevention. So it covered a range of things, including healthcare access, all the different biological systems. And generally, they were asked, do you have any problems with blah, blah, blah? Have you ever been told by a doctor, nurse, or other healthcare professional that you have blah, blah, blah? So people were able to endorse different things. We also looked at their substance use measures. They took the alcohol use disorders identification test. There was a drug test checklist. They had a urine drug screening, and we looked at GGT as a biomarker of behavior. There was a mental health survey that looked at psychiatric diagnostic screening questionnaire, looking at current symptoms of a variety of mental health conditions. They also sort of participated in a whole battery of cognitive tests called the NIH Toolbox, looking at a variety of different cognitive functioning domains. As I mentioned, they all were subjected to a dysmorphology examination, which is kind of a standard exam that measures a variety of things I'll get into a little bit more later, including their head circumference, their palpebral fissure length, their philtrum length, and looking at giving them a score based on what is called here a lipometer or lip philtrum guides, and also sort of the vermilion border or the thickness of the upper lip. As I mentioned, some folks at the Seattle site participated in brain imaging using MRI. And there was a longitudinal component to this that brought people back to UW who had already been imaged back when they were in their 20s. And we're hoping to get funded to bring them back yet again. But this study looked at intracranial volume, regional cortical and cerebellar gray matter, white matter, CSF volumes, and volumes of subcortical regions of interest. That is my brain, if you're so the data analyses really varied depending on the research question at hand. We were looking at between groups differences, looking at propensity scores, while also sort of taking into account relevant demographic variables like age and sex. But we were really interested in looking at interactions between things with group membership. So particularly the diagnostic group. As I mentioned, the cohorts are different. And so it's sometimes a little bit challenging sort of figuring out sort of how to put them together. Like we have people at UW, so based on their diagnoses. Atlanta has people based on dysmorphology. Vancouver has people based on actual diagnoses that they give to folks up there. And so figuring out how to group them across sites is a bit of a challenge. And I'll mention later sort of how we came down for dysmorphology study. But I'm just going to sort of quickly run through all of these findings without spending too much time on them, but I really want to sort of let you know the take-home messages without getting too far into the data until we get to the studies that we've done at UW. So prenatal alcohol exposure and health at midlife was published here, led by my colleague Claire Coles. The take-home messages from that, so looking at the health questionnaire, was that prenatal alcohol exposure was associated with more problems with hearing, teeth, skin, gastritis. There were more concerns related to heart, thyroid, more reports of diabetes and cancer. Now, this is compared to controls, age-matched controls. There were more reports of kidney stone and bladder disorders, and more reports of seizures. But the good news is that prenatal alcohol exposure was not associated with more problems with vision or sleep apnea, high blood pressure or cholesterol, attack or stroke, autoimmune diseases, allergies, asthma, arthritis, HIV, or hepatitis C. And I think that it's really important to sort of point out where folks with FASD are doing well, because I think there was some early studies that sort of said like they have all these problems and the premature death and all of this. So people with FASD were like understandably like really scared, like, I have this thing and like what's going to happen to me as I get older. And so there are a lot of areas where prenatal alcohol exposure does not subject. So I definitely want to point that out. Our study looking at substance use was published here, led by Cleo Huncutt Ferguson. Take home messages from looking at substance use and middle-aged adults with FASD is that prenatal alcohol exposure was associated with higher levels of adverse childhood experiences, which is not surprising. Their mother abused, used substances while she was pregnant. There's addiction in homes unless children somehow, get put into a different environment. So we see higher ACEs. But there were no higher recent negative life events. In fact, the people who actually had dysmorphology, like FAS group in Seattle and the dysmorphology group in Atlanta, and the diagnoses associated with dysmorphology in Vancouver, they actually had lower rates of substance use, which could be related to perhaps being a little bit more sheltered due to their disability. They did have higher rates of current tobacco use, but lower rates of alcohol use. So, that could potentially come from sort of, but you have this condition that was caused by alcohol. So you're not going anywhere near alcohol, right? We did see higher rates of cannabis use compared to the national average, but not compared to controls. And so that kind of just goes to show, in Seattle, it's one of the states with legal recreational cannabis use, right? So it might be related to, and in Vancouver also. I'm not sure about Atlanta. I think there's medical use there. So it just kind of goes to show, like, we don't really know, but in our settings where there's ready access to cannabis, it's higher cannabis use compared to the national average. There were no differences in rates of current or past use of any other substances. So it's noteworthy that people with prenatal alcohol exposure were not using substances more, in spite of the fact that they did have higher ACEs, right? So you expect to see a relationship between adverse childhood experiences and perhaps self-medicating with substances in adulthood. We did not see that in people with FASD. In fact, so they were showing quite a bit of resilience. So that's some good news. Our findings related to mental health were also led by Claire Coles and published in Alcoholism and Fun Experimental Research. The take-home messages from that were that prenatal alcohol exposure was associated with higher levels of depressive symptoms and prevalence of a depression diagnosis. There was also higher prevalence of diagnoses of anxiety, bipolar disorder, and ADHD. Now, we don't know if that's because they were prenatally exposed to alcohol or, because they had sort of other things going on in their lives that could be causing that. But it's noteworthy that prenatal alcohol exposure was not associated with prevalence of psychotic disorders, OCD, or PTSD. And so again, we're seeing some significant resilience here. It's noteworthy that people with prenatal alcohol exposure did not have higher rates of PTSD, although they did have higher rates of adverse childhood experiences. And that could potentially be impacted by the fact that, if you have a diagnosis, like you got it, at the University of Washington when you were young, people are more able to support you. And so you don't go on to develop some of these potential outgrowths. When we looked at cognition, we found that prenatal alcohol exposure was not surprisingly associated with lower scores on fluid cognition, executive functioning, cognitive flexibility, selective attention and response inhibition. But it was not associated with lower scores on working memory, episodic memory, or processing speed. So there's diverse impacts of prenatal alcohol exposure at the brain that persist into adulthood. So we're slide getting in place. I do want to sort of talk a bit more in more depth about studies that we did at with brain imaging, looking at brain structure. So there are 3 papers that have thus far come out of this work. The first one, we'll call study 1, was a longitudinal study looking at sort of the brain as a whole, the cortex and the cerebellum. That had 66 participants. The second study that was cross-sectional in nature, looking at subcortical structures. And then the most recent study was kind of a hybrid design, looking at both some longitudinal work related to the thalamus and thalamic nuclei, but also looking at cross-sectional work. So all of these studies looked at healthy controls, so people who presumably were unexposed, or at least they weren't exposed to the extent that they had an FAS or FAE diagnosis. But then there was a group with fetal with a diagnosis of MAE, and then another group with a diagnosis of FAS. So the first study was published in JAMA Network Open. And what you can see, this is again the longitudinal study where you can see they had their first scan when they were in their late teens, early 20s. And then they came back later and they had their second scan, generally in their 40s. And you can see this group was primarily Caucasian, but we did have some American Indian, Alaska Native participants. Only one, or only a couple of African American participants. Because again, this is the Seattle site. So we were looking at brain imaging over time. This, I'm not going to get into the details here, but looking at brains of people with FASD versus controls in their first scan versus their second scan. And just to sort of walk you through the findings here, what you see is you look at raw intracranial volumes, or so just whole brain size. What you see, control on the left, FAE in the middle, and FAS on the right, is that people with FASD have smaller brains overall compared to controls. But they also generally have smaller bodies overall, right? That's part of an FASD diagnosis, is growth deficiencies, right? So, we really want to know, well, what do they look like when you control for their brain size overall? And I'll get into that on the next slide. But when you look at change in intracranial volumes over a year per year, what we're really seeing here is some more variability, sort of wider boxes here in people with FASD. But these of note is these are not significantly different from each other. So we're not seeing evidence of accelerated aging in FASD when it comes to brain structures, or at least overall volumes. Now, if you control for brain size overall, and you're looking at effects, the scans overall, the ICDs, what you see is the significant effects go away. So folks with FASD should have, get smaller brains overall. But you do still see some differences in the cerebellum, comparing controls and people with FAS with people with FAE sort of falling in the middle there. But what you're not really seeing, scan 1 and scan 2 is a lot of downward, right, movement. So we're not seeing that the impacts of FASD get worse over time. They pretty much stay the same and are in the same direction as controls. The second study was in looking at subcortical volumes. And what we found is significant differences between people with FASD and people without FASD in some specific group brain areas in the basal ganglia, including the caudate, the putamen, the pallidum, the cerebellum, and the corpus callosum, which is very similar to what the research shows in children and adolescents. The caudate is related to motor control, cognitive processes, and emotion. It's related to goal-directed behavior, procedural learning, working memory, self-regulation. The putamen also is related to motor movements, particularly automatic or habitual motor movements, and also plays a role in cognitive functioning. The pallidum Also tied into motor control and precise muscle activity, coordinating voluntary movements, sort of key for balance, and sort of proprioceptive awareness. And the corpus callosum is sort of a thick bundle of axons in the center of the brain that sort of connects the left brain and the right brain. So when you have impacts of that, that's the sides of the brain sort of talking to each other, and so that they're coherence of functioning. Um, so, for example, in FASD, like what somebody hears might be not related to like what they are reading. So, anyway, coherence is potentially impacted. Now, if you sort of control for brain size overall, again, recognizing that people with FASD have smaller brains, where do you still see impacts? And what we see is, you still see a lot of these effects kind of go away, and you don't see a sex effect, but you do see a sex effect in the corpus callosum. So the corpus callosum was smallest in middle-aged women with FASD, suggesting that that group might have a bit more difficulty with that coherence in the sides of the brain. So then the final paper that we put out related to thalamic nuclei was actually very similar. I'm kind of running low on time, so I will sort of cut to the chase. And basically, if you control for brain size overall, a lot of the differences go away, but there were enduring impacts to different thalamic nuclei. And this is, but you're not seeing, again, like there's a lot of variability, and they're not significant when you control for ICVs. And that's way too much to get into, but you could say that adjusting for overall brain size showed just enduring size differences in thalamic nuclei. We don't know yet, what that means functionally speaking, but it certainly points us in directions for future research. So the take-home message here is that generally you see sort of graded impacts of prenatal alcohol exposure with FASD, FAS being more severe than FAE, certainly being more severe than controls. And you see that in the whole brain, particularly when you control for brain size overall, the cerebellum, the thalamic regions, and cortical regions. But the three groups showed similar patterns with aging. So even controlling for intracranial volumes, you still do see that folks with FASD were lower than the control group in volumes of variety of different brain areas, but we do not see an interaction between diagnostic group. So it's not getting worse than that. Yeah. So there were just evidence of persistent brain differences in brain volumetrics. People with FASD impacts, like their brains don't catch up in terms of size, but they also don't deteriorate. So there's no evidence of accelerated brain aging. So you can think about like running a race where people with FASD sort of start further behind. They don't. They might run the same rate, but they don't quite catch up, at least in terms of their brain size. But we're still looking at impacts related to as they get even older. So our findings related to dysmorphology examination. I can't show you the paper because it literally just got accepted this week. We were very excited about that. It's kind of a long time coming. But just to remind you about the cardinal features of FASD, here they are. This is a widely disseminated picture of a child diagnosed with FAS. The reality is we don't know what people with FASD, if you can detect, or we didn't know if you can detect those cardinal features in middle age and beyond. And that's important because not everybody gets a diagnosis in childhood. Can we use dysmorphology to help get a diagnosis when they're later in life, adulthood and beyond? So what I did is I ran this picture through AI to see what does the AI think that little girl would look like when she grew up. And not that different from anybody else you might sort of see on the street, right? In fact, wanted to just show some pictures of some celebrities over time, and if you look at their upper lip, it it does sort of look smaller, although there is quite a bit of variability. Um, but we looked at people again, sort of put them together based on did they have no FASD diagnosis or no prenatal alcohol exposure? That's the no FASD group. Was and then did they have low dysmorphological features or high dysmorphological features when they were children? Right. So looking at that, we did some hierarchical multiple regression analyses, and we were looking at a variety of different dysmorphological measures. And what you see here is that we actually did still find significant differences in head circumference. I mean, that's something that generally doesn't change as you get older. Or and palpebral fissure lengths, your eye width doesn't generally change when you get older. And even though your lips might change as you get older, they're still detecting, and these are blind dysmorphological examinations. The rater did not know people's diagnosis. Still seeing significant differences in ratings of the lip and the philtrum. So this suggests that there might still be a role for dysmorphology examination in diagnosing people in adulthood. But of course, there would need to be norms developed for that. We also found that sex moderated some of the findings where the philtrum was differences were most noticeable in females. And also we found some moderation by race and ethnicity where the differences in the lip were most noticeable in non-Black individuals, and the philtrum length was significantly different in Indigenous folks, particularly in the control group. So the take-home messages here are that individual differences in physical characteristics, including alcohol exposure, continue to be observable at midlife. In particular, those cardinal differences remain significantly different when you control for age, sex, and race ethnicity. But sex and race ethnicity did moderate some of the findings. So we think that dysmorphology examination could continue to be useful, but you're going to have to take sex and race ethnicity into consideration and develop reference guides from people from different genders and different racial and ethnic backgrounds for this to be useful at all. So a lot of work still needs to be done if we're going to use this for diagnosis, but this is really an important first step in terms of looking at adult diagnosis. So in summary, we've sort of flown through a broad swath of emerging findings on physical and mental health, substance use, cognition, physiological characteristics with folks with prenatal alcohol exposure at midlife. The story here is largely one of persistent differences between groups over time. So at midlife, we see not only whole body impacts, but whole person impacts. But we're not, the good news is that we are not seeing evidence of accelerated aging at midlife as we were expecting to see. So that is really good news. In fact, in several areas, we see ways in which middle-aged adults with FASD are similar to their peers and or doing better than might be expected, particularly with respect to substance use. So they're showing, again, evidence of remarkable resilience. But more research is certainly needed to continue to develop our understanding of the impact of prenatal alcohol exposure as people age. So I want to acknowledge our funding from NIAAA, the National Institutes of Health, and my collaborators at Emory, University of British Columbia, Calvin Brock, the support of the Collaborative Initiative on Fetal Alcohol Spectrum Disorder, my colleagues, some of the researchers involved in the MRI work at other universities. Certainly want to acknowledge the MRI work by Anne Streisguth, who's here, the force of nature herself, and other colleagues at UW. And with that, I will say thank you so much. If you'd like to know more about our research or fetal alcohol and drug unit, there's QR code right here. You're certainly welcome to email me. My address is right there. So thank you all for your attention. I really appreciate you.
You have a question.
So we have a few questions, and then we will have a reception after this until 1:30 when we'll have our practitioner workshop. So Dinah.
Okay. My question is there a certain time period in pregnancy in which the infants have the facial disformities? Is there a critical time for that? So maybe some fetal alcohol people don't have those facial deformities?
Yeah, my understanding, I'm a psychologist, so not super dialed into the prenatal development, but my understanding is that facial features really start to take shape in the first trimester, and so that's why we say that and also the brain is really developing as well. Uh, so that first trimester exposure is kind of the most significant. But again, there's just a lot of variabilities. And a lot of factors that go into that.
And my second question now is correlation between autism and prenatal exposure. Has been research on that.
I think that is a growing area of research, and there's a lot of sort of diagnostic overlap, particularly as we've sort of expanded our understanding of autism as a spectrum. And so we do see a lot of folks with FASD who have sort of both diagnoses. There's also a lot of overlap with ADHD. So there's some work that is trying to sort of tease those apart and sort of understand, you know, what accounts for both both kinds of spectra, if you will. Um, and my work in adults, I think that's a really interesting issue. Although like FASD, autism spectrum, is a relatively new diagnosis, and so trying to sort of catch up and diagnose people in adulthood and try to understand like retrospectively so that I understand impacts of what we're seeing in adulthood. And that's why longitudinal research is sort of really critical. If you could have people who for sure were diagnosed in childhood, and then sort of look at the trajectory of their lives and how they develop, can really help us really tease that apart better.
Thank you.
About a century ago, the US did an unintentional experiment called prohibition, where for about 13 years, drinking was greatly reduced. Has anybody looked at the impact of that on national and regional politics and crime rates?
That's a good question. I don't know. Not familiar with that literature, but it's interesting because one thing I thought would be interesting to do would be to go into long-term care settings and see if we can see in, I obviously you can't establish for sure like maternal drinking in that kind of setting, but somebody would be able to say like, oh, I know for a fact that my mom didn't drink, it was prohibition and she wasn't drinking or whatever when I was born. Versus, well, yeah, I know my mom. So they talk about going to speakeasies and she drank all through the pregnancy because they thought it was helpful. Yeah. And then just sort of see, if you can sort of identify, like sort of looking back retrospectively, if they've had some more secondary disabilities in their life. And if you can imagine folks in a long-term care setting with FASD, they might be sort of experiencing more struggles there, people not understanding them and trying over medicating them, that's creating more problems.
Now, I'm wondering if fetal alcohol defects has anything to do with our current political situation.
Yes, you do. Is there any online? There's some questions. Thank you, by the way, for being online. I didn't acknowledge all the great people online.
So Jamie asks, how do you approach a conversation with a family if you're seeing the facial dysmorphology, some developmental challenges for a young child in early childhood care, suspect could be related to FASD?
Ooh, that is a good question. My colleague Heather Carmichael Olson has developed an energy called Families Moving Forward with Diagnosis. And I think she would be much better able to speak to that. But I think obviously it has to be approached with really great sensitivity from a place of wanting to try to explain and help to connect people to services. And you don't even want to start that conversation unless you are prepared to sort of connect somebody to support. Like you don't want to discover something that you have no answers for, right? So you want to like be prepared to sort of connect people to the supports that they need if there is prenatal alcohol impacts of prenatal alcohol exposure leading to an FASD diagnosis. But for a lot of people, we hear this from adults. There's I'm not sure if you're familiar with the international meeting that takes place in Seattle every year, formerly in British Columbia. But bringing together researchers and folks with FASD, and we hear from folks with FASD very strongly that getting that diagnosis was super meaningful for me. It explained so much about the things that I was experiencing that I had no understanding. I thought I was just dumb, right? Or I thought I was just, lazy, but like actually had, executive function issues related to prenatal exposure, for example. So it really helps to explain what they're experiencing and then provide, if you can be like, okay, we understand this, we can connect you to these supports. But also the supports have to exist, and that really varies from state to state, unfortunately.
Anything else?
One.
One more. We'll do our last.
Rose says, yeah, as we saw a few moments ago, people sometimes use an accusation of fetal alcohol syndrome as a put down. Did you notice any psychological effects of this sort of otherness society in adults who were diagnosed in childhood?
That's great. Another thing that we hear a lot from folks with FASD is there's quite a bit of stigma. And so obviously people who come to an international FASD meeting, they are, putting themselves out there in spite of the stigma, and they're finding community that, where the stigma is reduced, let's say. But that is really a significant consideration. And also among mothers, right? It's very stigmatizing to sort of say that you used alcohol during pregnancy, especially now that it's pretty widely known that that's potentially harmful. But people who use, are using because they can't stop. They obviously have a problem. They're not wanting to hurt the child. And so, there's also, can be some impacts of adults with FASD, like feeling toward their parent, like you saddled me with this condition because of your behavior. So that's just sort of another potential impact. But I don't know if I answered the question. It is certainly a stigmatized condition. So that's why somebody might not want to go for a diagnosis. But I do think it's really critical for folks who do want to sort of have that explanatory diagnosis to sort of have systems in place to sort of help them understand their own behavior or challenges that they've been facing. Sorry.
Quick question, hopefully, because I know we're at overtime. When you think about freshly diagnosed FASD, midlife to some nature, is the help along the lines of psychology or is it occupational therapy? Because occupational therapy, there's some specialists in autism with occupational therapy. Would that be similar?
Yeah. Well, and I think that there are a lot of different systems that can provide them supports, including occupational therapy, speech therapy, which is, from what I've learned, is about more than just speaking. Right? Also, physical therapy, you see the motor impacts. As a psychologist, I, have to be honest that I think the field of psychology is pretty far behind in terms of adapting mental health treatments to people with neurodiversity. We have these evidence-based practices and they've all been tested without regard to neurodiversity or or, in some cases, people with neurodiversity are actively screened out, right? We need to have more inclusive research designs that can help us inform adapting our mental health interventions to people with differing needs. And so I'd like to say, people with FASD, to the extent that they're suffering from depression and anxiety, I'd like to think they could get meaningful support from mental health practitioners, but in some cases, mental health practitioners, in a lot of cases, are going to be ignorant of FASD, and and not only that, they're going to be, unaware of how to adapt their approach to somebody with FASD. So I think a lot of work can be done in terms of training the workforce and neurodiversity in general, and FASD in particular, and how to adapt your methods to work with people according to their strengths.
Thank you. Thanks, everybody.